Hello friends, this is Parshatwal and welcome to my YouTube channel. And today I'm here with drugs for peptic ulcers and GERD. So we must know the basic terminologies related to peptic ulcers and GERD. So first of all, first term is gastritis. So going by the definition, gastritis is the acute inflammation of the lining of the stomach. So it is due to more of the acid production. So it is the acute condition, and when it involves the inflammation and the degradation of the innermost layer of the stomach, that is mucosa, and causes some of the ulcers, small ulcers in the parts that are exposed to acid, like stomach area, then part of the pyloric sphincter, and then part of the intestine. So if these are involved, these will be called peptic ulcers. If stomach is involved and part of the small intestine is involved. So GERD is gastroesophageal reflux disease, in which the gastric acid is refluxed back into the esophagus. So what you will do on all these things, what all the drugs will be acting for this, you must know normal mechanism, how the acid production is increased, how these are kept in normal ranges, and what all the factors are contributing. So first of all, going by the two factors, there are two factors, aggressive and the defensive factors. So aggressive factors will tend to shoot up the production of the acid, whereas the defensive factors will ultimately try to keep the balance and to keep the acid in the optimal ranges, so that acid pH may not rise and their erosion of the stomach mucosa or intestine may not be there. So aggressive factors are more of the acid, more pepsin, more of the bile, and H. pylori infection of the stomach. So defensive factors include, just to keep balance between the when acid productions are more, there is gastric mucosa, bicarbonates just to neutralize the acid produced, prostaglandins are the parts of the gastric mucosa, and these provide as some of the protectant of the gastric mucosa. So then nitric oxide, what they will do, this will cause high mucosal blood flow, and when there will be high mucosal blood flow, what will happen, the gastric mucosa will be enriched and there will be more production of the mucus. So acid secretion. So acid secretion is by the parietal cells. So parietal cells are having hydrogen potassium ATPase pump. So in hydrogen potassium ATPase pump, what happens? Hydrogen is secreted in the apical canaliculi, and then pH starts to decrease. So pH of the stomach is 1.2 to 2.5. So this is how, by the activation of hydrogen potassium ATPase pump, hydrogen is secreted in the apical canaliculi, leading to the acidity, increase in the acidity of the stomach. And what this will cause? This will cause the lowering of the pH of the stomach, just to call the churning of the food and to emulsify much of the carbohydrates then and there in the stomach only. So you must know that proton pump is activated by basic three of the chemicals like histamine, acetylcholine, and gastrin. So when histamine, acetylcholine, and gastrin will act on the stomach, it will activate the hydrogen potassium ATPase pump, that is proton pump, and then hydrogen will be secreted in the apical canaliculi, and it will add on to gastric acid, and thus pH will rise. So histamine, acetylcholine, and gastrin, how do they act on the stomach? How do they activate? So this is how. Histamine, when there will be histamine release in our body, it will act directly and it will activate this hydrogen potassium ATPase pump, that is proton pump. Whereas acetylcholine and gastrin, what they will do, they will activate the histamine release. Histamine release from enterochromaffin like cells that are present in the paracrine cells, that are secretory cells. So these all I had discussed just to let you know that how the normal mechanism is there, how this acid production is there, histamine, acetylcholine, and gastrin. And when talking about the degradation of the stomach or part of the small intestine, that is basically duodenal area, what will happen? More of the acid, more of the pepsin, bile or H. pylori will degrade. And these are the defensive factors like gastric mucus plus bicarbonate, prostaglandins, nitric oxide and mucosal blood flow cannot keep pace with these of the aggressive factors, then this will lead to peptic ulcers. And if there is any of the problem in the sphincters like cardiac or pyloric sphincter, or if you are just lying down even after your meals, then you will be suffering from GERD. So next we will be discussing about the classification of the drugs that act on peptic ulcers and GERD. So you must know that all the drugs that act for peptic ulcers and GIT, even to inhibit the acid production, all are not antacids. So just to rule this out, we will be discussing about the classification of the drugs that lead to decrease or reduce the acid production. So reduction of the acid secretion is by major 7 of the drug classifications. So first of all, we will be discussing about H2 antihistamines. So what they will act ultimately on the histamine, acetylcholine and the gastrin, and histamine release will be controlled. So there are the drugs. What is the way to remember them? Sime, Rani, Famo, Roxa, Vertidine remains the same. So cimetidine, ranitidine, famotidine and roxetidine. So cimetidine was the prototype drug. So why it is not used nowadays? The reason is because it has anti-androgenic effect and it leads to gynecomastia, that is a development of the breast in the males. So because of other side effects, also diarrhea and acute rashes and all, cimetidine was given off. And now the most employed drug, that H2 antihistamine, is ranitidine, that comes in Asiloc form. So Asiloc or Rantec. So dosage is 150 to 300 milligrams, which could be once daily or twice daily. So next classification is proton pump inhibitors. So proton pump inhibitors directly act on the proton pump and inhibit the acid secretion. So what all are these? So here also to learn ome, isome, pento and rabi. So where prazole remains same. So omeprazole, isomeprazole, pantoprazole and rabiprazole. So these are the drugs that are proton pump inhibitors. So in these also H2 antihistamines, these are 4 and there are 4 proton pump inhibitors. So next one is third type, that is anticholinergics. So you must know when we give anticholinergics to the patients, all of these secretions are lowered. So just these are added on to lower the gastric secretions, but these are very less employed in the practical usage. So these are pirenzepine, propanthelin, etc. So next one, these are prostaglandin analogs. So prostaglandin analogs, just to provide some of the protective covering to the mucosa. So these add on to provide the protection. So these are misoprostol, etc. So then is neutralization of the acid. So these are basically antacids. So all of these adds to antihistamines, cimetidine, ranitidine, famotidine, roxetidine, and proton pump inhibitors like omeprazole, isome, pantoprazole, rabiprazole. So these are not antacids. So next one is neutralization of the acid. There are 2 drugs, 2 classification, further classification like systemic and non-systemic. So systemic, it comes that acts on whole of our systems like soda bicarbonate, sodium citrate. So non-systemic includes magnesium hydroxide, magnesium trisilicate, aluminium hydroxide gel, etc. So these will be given just to neutralize the acid and to enhance that some of the time is provided to the gastric mucosa so that it may heal itself. So next one is ulcer protectives. So ulcer protectives you are very often prescribed if you are suffering from the peptic ulcer and those are not healing. You will be given some of the ulcer protective like syrup sucramyl. So syrup sucramyl that has sucralfate in it, and other what we have in form of emulsions or syrups. You can commonly refer to as syrups, but syrups is not a technical term that must be referred to. So next one is CBS, that is colloidal bismuth sulfate, and it is also a ulcer protective. So next drug is anti-H. pylori. So the next final category is anti-H. pylori drugs. So anti-H. pylori drugs act on the H. pylori. So H. pylori is gram-negative organism that affects the stomach, and it releases histamine, and histamine increases the production of the acid ultimately. So what are the drugs that we give in anti-H. pylori? These are beta-lactams like amoxicillin, then clarithromycin, that is macrolide, and azoles like metronidazoles and tinidazoles, and then tetracycline. So you must note, when you are giving tetracycline, chelation could be there. You must not you must take care for it. So then there are few points to remember. So H2 antihistamines like ranitidine, if you are giving IV and the dose is very large, that is exceeding 50 milligram, and you're giving direct IV, you must take care that you must not give IV bolus, or you must not rush. So if you are rushing, what will happen? Patient will BP will fall, and patient will be in bradycardia, and some of the most it could lead to some of the serious complications. So if the dose is above 50 milligram, just see to it that you are giving very, very slowly. And then next thing to be noted is once only dose of proton pump inhibitors like pantoprazole, omeprazole, esomeprazole, lansoprazole. So these are once single dose of proton pump inhibitors are effective because these have longer T-half. Approximately 10 to 12 hours T-half is there for proton pump inhibitors. So we do not give BD doses of proton pump inhibitors like pantoprazole, that is most commonly employed. So next one is colloid bismuth sulfate and sucralfate. These are ulcer protectives, and these must be given 1 hour prior to meals or empty stomach. So these are the indications that you must keep in mind, that if patient is having sucramil or some of those syrups that are told, so these you must guide to the patient that he must take this 1 hour prior to the meals or empty stomach. So these are one and the same thing, prior to meals or either empty stomach. So you must take care that these are not to be taken with antacids. CBS and sucralfate, these are not to be taken with antacids, like antacids as we had discussed, like magnesium trisilicate, magnesium hydroxide. So these are the things that these must not be taken with the antacids. And CBS and sucralfate, these causes some of the ADRs like constipation and nausea. So then if GERD is there, gastroesophageal reflux disease is there, what you will teach to the patient that he must not lie down immediately after he has had his meals. So then you will say to patient that you must walk after you have your meals for at least 10 to 15 minutes. You must not lie down up to 10 to 15 minutes after you have your meals. And apart from the H2 antihistamines, there is a choice H2 antihistamines we can give, but there are proton pump inhibitors are more potent. So in GERD we give mostly proton pump inhibitors, and then sometimes prokinetics are given. So prokinetics, what they do, they increase the gastric motility. So gastric motility will be increased, and there will be hurrying of the emptying of the gastric contents. So this will decrease the risk of the GERD. So prokinetics are just like metoclopramide, that is Perinom, and others are there like domperidone. So these are also prokinetics. So diet. So you must say, if a person is having peptic ulcers or GERD, you must take plenty of fluids. You can take milk, and you must have very light meals. You must avoid the spicy meals. So overall, to conclude, so today what I had to tell you that to clear the notion, most common notion, that all the drugs acting for peptic ulcers and GERD are antacids, because I have most often heard from my experience that people refer to ranitidine and proton pump inhibitors and other things to be antacids. So these are not antacids, and there are some of the conditions, very few conditions, that you must remember while the drugs you are administering, and some of the patient's education. So thanks for watching my video, and if you like the video, just give a thumbs up and subscribe to my channel. So thank you.